So, as I said to you, that this patient has the gastroduodenal artery attenuated. This means that there is invasion, but up to when this invasion is? Is it reaching to the common hepatic, to the celiac, or not? But the superior mesenteric vein and all the other parameters, the aorta, the IVC, are away from the lesion. So this will be classified as borderline resection. Borderline resection. This means that the decision should be taken in a council, including the surgeons, the oncologists, the oncology, the radiology together, and they will decide. And we'll speak about the borderline resection. This one, as you see, the hepatic artery up to the celiac. The hepatic artery up to the celiac is clear. أنا ما بستخدم البتاع ده مش كده. IVC is clear. The aorta is clear. The common hepatic is clear. So this is a resectable case. This is a resectable case. The common case, if we look to the picture on the left side, you will find that the hepatic artery is infiltrated. So we come to a point we are not going to solve either by neoadjuvant or by surgical techniques. However, there is nowadays complex vascular techniques that can be done in such cases. I will speak for it later on. It's apparent in the middle picture, and if we look to the picture on the right, you will find the superior mesenteric vein is encased completely by the lesion. So this is unresectable case. This is also the last picture here. You will find that the superior mesenteric vein is just touching the tumor, abutting the superior mesenteric vein, but not encased. In the middle picture, you will find the celiac trunk and the superior mesenteric artery are free from the tumor. And the picture on the left, you will find the hepatic artery is there, clear from the tumor. So this is a resectable case because it's just touching and not encasing the superior mesenteric vein. But in this picture, look to in the middle picture, you will find the tumor is reaching to the aorta. So the aorta is not there. And on the right one, the superior mesenteric vein is also included with haziness around it. This haziness may be infiltration of the tumor or collaterals due to complete obstruction of the superior mesenteric vein. So this case is unresectable. The same thing here. You will find here collaterals apparent completely here around the superior mesenteric vein, which is entrapped inside the tumor. And in the middle picture, you will find the superior mesenteric artery is encased. So this patient is also unresectable. Which of these is a resectable tumor? أنا أسأل الجراوند عشان أشوف كلامي يعني يتفهم ولا لسه. برافو عليكم، أنا كده طلعت بتاع أشعة صح مش. This picture, because we are going to speak about this matter later on, this picture has been done for one of the surgically resectable cases 8 months after it. Although all the investigations was negative regarding metastasis, because metastatic workup should be done in all cases, but this happened after 8 months. This means that we have a problem in the detection whether the patient has already small metastatic nodules, especially in the liver and the peritoneum, or not. Other investigation alternatives دكتور عاطف بيه الام ار اي انا كاتب كده هنا انه problem solving if the mass is not identified in CT and this ايه رايك؟
طبعا زي ما احنا عارفين ان السي تي ترايفيزك زي ما الدكتور احمد وانت قلت سعادتك ان this is very important لان هو ده اللي بيديترمن basically decision making. انا كنا زمان الديسيجن ميكنج بيتعمل في الاوفيس. This is a resectable borderline or resectable according to the tumor relationship of the SMA artery. As regard the MRI ده بنعمل dynamic MRI ده طبعا في حالة ان لو كان حاجة tumor very small tumor او usually بيبقى في unsennate process. عارفين unsennate process tumor بيبقى presented only with epigastric pain radiating للباك وusually there is no jaundice. بيبقى mainly pain وده طبعا بيبقى ده اللي برضه بيدي delayed diagnosis. usually اللي بيقدر يجيب السمول سايز ده الدايناميك ام ار اي يا دكتور
يحيى. تمام بس احنا كده بقى ايه مش طلبنا المحل كله. احنا ابتدينا بالسي تي اللي بيحل المشكله في حوالي 90% من العيانين. في 10% بقى ممكن نحتاج فيهم لأذر انفستيجيشن زي ما قال الدكتور عاطف. ممكن تلاقي زي ما فرجتكم اول صوره الدبل دايلاتيشن ده في الكومن سي بي دي وفي البنكرياتيك داكت، لكن في البنكرياتيك ليجن مفيش اي ماس، ودي حقيقي بتبقى مشكله في السي تي. لان في حالات هنا بقى زي مثلا الكولانجيو كارسينوما في اللور اند اوف كومن بايل داكت، البري امبولاري كارسينوما زي ما قال الدكتور عاطف بيه، دول مش هيبانوا في السي تي لكن هيبانوا افضل في الام ار اي. فانا لما الاقي السيتويشن دي الجا بقى للام ار اي عشان بس ما نقولش ان احنا بنعمل كل حاجه. لان انا بشوف العيان عامل سي تي وام ار اي وام ار سي بي وايه تاني وبيت سي تي لازم نبقى يعني نبقى داخلين في ان دي كلها كوستس حقيقه لازم نحاسب عليها. في الحاجه الثانيه ان في بعض التيومرز البنكرياتيك ادينوكارسينوما العاديين خالص بيبقوا ايزو اتنيويتد حوالي 7% اوف كيسز، يعني ما تلاقيش ديفرنس في البرينكما ما بينها وما بين النورمال بانكرياس. البيت سي تي حليناه بس في الهاي ريسك بيشنتس. دكتور طارق يقول لنا بقى البيت سي تي نطلبه في امتى؟ باعتبارهم اكثر ناس يطلبوا البيت.
لا طبعا زي ما دكتور احمد قال sometimes في ابيوز للبيت سي تي. بس انا عايز اوضح حاجه. طبعا انا قاعد مع في جامعه من الجراحين.
انا بك.
في كل اللي اتقال you are focusing about resectability. يعني انتوا في كل الكلام كل investigations you are focusing on whether the patient is resectable or not. But لما تيجي at the end of the day تيجي تبص على percentage of patients who can be resected هتلاقيهم قليلين جدا.
استأذن حضراتكم معنا ضيف فنحاول نتكلم بإنجليزي as possible. هو لسه واصل دلوقتي.
Okay. So I mean when you talk about the proper investigations to diagnose patients with pancreatic cancer, in your point of view as a surgeon, you are concentrating on whether the patient is resectable or not. But at the end of the day, as I'm saying, the minority of the patients who are get benefit or are candidate for surgery. So still PET scan is important for part of it to exclude whether there is metastasis or not, or in the follow-up of the patients. My question here is, and I have another question for you and the panel about the biopsy.
جاي دور.
اوكي خلاص.
لا لسه جاي دور. It's coming. So as we said here, PET-CT is only indicated in high-risk patients. What are the high-risk patients? Means high risk for metastasis. No doubt about that. No doubt about that. وانا معايا صور كتيره وفيديوهات بس مع الاسف يعني لما الدكتور محمد ما حطتهاش مهمه جدا مهمه فوق الغايه. ساعات تلاقي الفيرست جيجنال برانش مثلا الفيرست جيجنال برانش توتالي انفلتريتد. هتعمل ايه؟ اي محاوله للريسكشن هنا معناها انك هتلاقي انتستينال جانجرين جي 1 جي 2. اتفضل بس ده اخر بقى بتاع لا بالظبط بالظبط essential حقيقي. لو انت بلاننج، لو انت بص الموضوع اصله ماهوش فيكسد، وعشان كده يعني the problem is we have to reach with the patient.
تحب اضيف حاجه يا دكتور يحيى بعد اذنك؟ as regard the CT angiography يعني هو الحقيقه debatable يا دكتور احمد، بس احنا لو suspecting ان انا عندي infiltration للجاستروديال artery that might progress to hepatic artery, that at that point you have to do, and once the hepatic artery is infiltrated, this is inoperable patient. Do you agree? This is the only indication for CT angiography. If you guys this is debatable. انما otherwise احنا mainly او entirely على CT pancreatic protocol وزي ما قلنا، وكل ده وده اللي بيدي decision making pre-operatively in the office. You make the decision in the office. طبعا لو هو هياخد نيو adjuvant ده برضو ده من المالتي ديسيبلينري ابروتش اللي احنا هناخده برضو هنتكلم فيه من خلال الدكتور ده.
ثانية أقول حاجة بس. we are going with the patient step by step. If suppose the pictures which I show to you that this is a resectable cases, the lesion is far away from the hepatic artery, is far away from the superior mesenteric artery and vein, is far away from the aorta and portal vein and the inferior vena cava. Why should I ask for CT angio? But in the borderline resection cases, yes, I have to. The gastroduodenal artery is infiltrated, so I have to look for. This means step by step. But if you have a patient which is borderline, you have to perform angiography before in order to plan for surgery, to plan whether you are going to detach one of the vasculars and reconstruct or not. عشان هنوفر في النقطة دي شوية واحدة بس. فالبيت سي تي الهاي ريسك patients means high risk patients of having distant metastasis. Suppose a large pancreatic tumor, so it is suspected to have metastasis. A very large regional lymph node is suspected to have metastasis. An elevated CA19-9, 800 or 1000 or so on, it is suspected to have. So in such patients, I have to perform PET-CT. Regarding the role of AOS, currently in pancreatic cancer, in diagnosis, staging, accuracy, and biopsy, Professor Dr. Al-Ansari is going to talk about this.
Changing the slides.
I will change it.
Thank you, Professor Yahya, for this kind invitation, and I am very happy to be with my dear professors, great surgeons here in the Society of Surgery and Egyptian Society of Surgery, and also I am very proud to have my dear colleagues and professors, Dr. Ahmad Asmat and Dr. Ahmed Abdelaziz, Dr. Hisham from Tito Orbel Arts Research Institute. Actually, I am going to answer or just throw light on many aspects. Maybe Professor Yahya has covered a lot of my points. Just reminding that the primary solid pancreatic neoplasms mainly exocrine 95%, and mainly pancreatic ductal adenocarcinoma 85%, and only 5% endocrine tumors. But keep in mind that if I have mass in the pancreas, it could be either adenocarcinoma and neuroendocrine tumor, and the management, of course, will differ. Surgical resection, of course, as Professor Yahya covered this, only 15 to 20% of patients, when they are discovered, they are only 20% are candidates for surgery, and the 5-year survival. Next, please, Professor Yahya. Next slide, please. Yes, this just showing you that how staging is important and the size of the lesion. If the size of the lesion is less than 2 centimeters, so the chance of survival is about 50%. If it is more than from 2 to 4 centimeters, a chance about 30%. If it is more than 4 centimeters, a chance is very low. And also, as regards the nodal involvement, if we have 3 nodes, the chance of survival, 5-year survival, about 30%, and when it is, without nodal involvement, about 30%, without, with N1, 3 nodes, it is about 10% or 15%, and it is more aggressive when we have N2. Sorry. Next, please, sir. Yes, this just, I will pass it very rapidly. When we have risk factors, we suspect patients are prone to develop pancreatic cancer. We have to think of genetic aspects and the family history. We have to think of non-hereditary factors, for example, heavy smokers, obesity, diabetes, as Professor Yahya said, chronic pancreatitis, the gender, and the age. Of course, H. pylori has nothing to do with cancer pancreas. Next, please, sir. So this is a point of screening. When I suspect in high-risk patient, I have to do proper screening, imaging, and even endosonography. Next, sir. No, excuse me, the previous one. No, the previous one, sir. Yes, actually, why we need EOS? Why we need EOS? Of course, first, we have to compare it with imaging, because we may resort to EOS in certain situations, as I'm going to mention. Also, we have to think of tissue diagnosis. Tissue is the issue, as we have learned. Tissue is the issue, because we have differential diagnosis of primary adenocarcinoma. We may have other lesions, not adenocarcinoma. And as I'm going to show you in next slides, also staging is very important, and I'm going to raise the issue of EOS in staging and detecting resectability. Next, please, sir. Just this long table showing comparative studies between the sensitivity of EOS, CT, and MRI, and even PET-CT as regards detection of the tumor. And here the EOS showing superiority, but in this table, actually they were not using the contrast-enhanced multi-detector CT, as Professor Ahmed said. Nowadays, the advance in CT will improve the diagnosis of cancer pancreas and detect more. So this study actually is before the multi-detector CT for the pancreas. Next, sir. This is also a very concise slide showing that the accuracy involves 2 aspects: the detection of the tumor itself, and also detection of nodes, the detection of hepatic mets, the staging itself as regards the vascular involvement. as my dear professors talked about before. So for detection of a lesion, actually EUS has superiority in detecting smaller lesion, even if it is less than 1 centimeter. If we have a lesion less than 1 centimeter, we can detect it by EUS, and it has superiority over the multi-detector CT for the tumor itself. But for the nodes, actually, the multi-detector CT is more sensitive than EUS in detecting lymph nodes. This is as regards detection. As regarding staging, actually, there is very important point I have to mention that nowadays multi-detector CT, as my dear professor said, CT angiography is very sensitive in detecting vascular involvement. So EUS and CT are comparable. So EUS has no superiority in detecting vascular involvement. As regards the MRI, also MRI and EUS are comparable as regards the resectability. But I have to mention, EUS has a role in tissue diagnosis, as I'm going to say in next slide. Next, sir. Yes, I like this slide so much because it was found that in patients who has done Whipple, they found that 6% of the patient has no adenocarcinoma. They have other pathology. They have, and the other 6% have benign lesions like focal autoimmune pancreatitis. So just keep in mind that we may have non-neoplastic focal lesion in the pancreas like autoimmune pancreatitis, focal fatty necrosis, and even pancreatic splenosis. And again, for the neoplastic, it is not primary only. We may have secondaries because pancreas is a seat of secondaries. So we have renal cell carcinoma metastasizing, here cancer lung, here we have the renal cell carcinoma. And this picture showing that we may have pancreatic ductal adenocarcinoma and we may have neuroendocrine tumor. So how to discriminate between all these things? Unless we have proper history, unless we have tissue diagnosis in such situation, for example, non-functional neuroendocrine tumors. Again, this long, it has a lot, but just I want to show you that endosonographer should know staging. I have not to do endosonography without knowing proper staging. So this just showing you how the size is important for T staging, for N staging, the number of lymph nodes, how they are important, and remind you that by EUS we can detect small hepatic focal lesion, less than 1 centimeter. The picture that my dear professor showed us, Professor Yahya, that after 8 months the patient has metastasis in the liver. Actually, this patient, if he has EUS before surgery, we may detect such small lesions less than 1 centimeter, and we even take FNA from such lesion. So this is the importance of endosonography nowadays.
Okay.
Just this is apartment and encasement, like my professor said. Again, like my professor, but this is the endosonographic pictures. How there is apartment. Again, next, sir. This is the encasement, how it is involving and infiltrating more than 180%, 80 degrees of the wall of the vessel. Next, sir. Here, just show you, maybe I am different somehow. I don't know I am different or not, but as regards the borderline resectability, when they said when the solid tumor involving sphenomesenteric artery less 100 degree, it is borderline. And also the Anderson said that if the celiac axis involved less than 180 degrees, it is still borderline. But many centers refuse that. They only accept sphero-mesenteric artery involvement less than 180, that is to say abutment. And for the veins, if there is abutment or encasement, this is my different point. If there is encasement more than 180 of the portal vein, also sphero-mesenteric vein, still it is borderline so long as it is reconstructible. So it is for the surgeon to decide. For the unresectability, as my dear professor mentioned, I am not going to say more. Next, sir. Now, as regards the FNA and FNB, this is very important issue because tissue is the issue. First of all, there are certain factors that affect sensitivity. Sorry, sir. This is just saying that how is sensitivity of US is affected, because sometimes we have many situations. We have US saying that there is chronic pancreatitis, but there is mass inside. So chronic pancreatitis may affect sensitivity. ERCP, if we have a stent prior to EUS, may affect detecting of small tumor and also acute pancreatitis. Next, sir. This next نرجع حضرتك، احنا كده راجعين. لا نكست ساعتك. لا احنا كده بنرجع ساعتك. ايوه نكست بقى. هنا احنا مهم قوي الاف ان اي والاف ان بي فور ريسكتابل اند ان ريسكتابل تيومر. يعني انا موافق مع حضراتكم لو عيان ثانيه واحده لو عيان ريسكتابل سمول ليجن وريسكتابل وديتكتنج باي ايمجينج you have not to do EUS. But if it is resectable and unresectable, لو borderline resectable or poor surgical candidate or unresectable, we should have FNA. Okay, so this is the role of histology. Just this is algorithm.
We will talk later.
This is خلاص ممكن نمشيه. دي types of the needle والstages بتاعتها، ودلوقتي احنا بنتكلم في الاف ان بي اللي هي البروكور نيدلز او الاكواير نيدلز اللي هي بيبقى ليها بيفلنج وبتاخد تيشو جود كور. نكست سير. مشيها حضرتك كده. ايوه دي just step for EUS for endosonographer. It is very important this slide. Next sir. Yes, this is the difference between FNA and FNB, and actually many studies now they said that FNB is equivalent to FNA. Although we now, all of us in most of the centers of endosonography, we use the acquired needles or the Brucor needles because, next sir, we have now molecular biology and we have genetic studies for the sensitivity of the tumor to the different chemotherapeutic agents, and consequently we may have a lot of studies that shows the sensitivity of the tumor to the chemotherapeutic agent, and consequently we have in the future we may have all these lots of studies, genetic studies, and they are in practice nowadays, I think, for detecting the sensitivity of the tumor to the chemotherapeutic agent. Next, sir. Just picture showing you how they use the tissue in which they expose it to organoid, the so-called organoid establishment and pharmacotyping, and also the DNA studies and genetic studies of the tumor, of the cells of the tumor. Next, sir. Just here, this is showing the previous.
We'll about this later.
This is about EUS and ERCP in biliary drainage.
This is coming later.
Okay. Thanks.
Thank you.
Thank you.
I have two questions for you, Professor, because for the ground. Before EUS, we are accustomed to have the biopsy percutaneous. And when they make studies about that, they found that about 10% of cases have transceramic extension of the tumor from the site of the biopsy. This is what the US avoided, because usually when they take the specimen, they take it from the duodenum, which is already will be resected with the pancreas. So, but the situation is different in the body until it's not our concern nowadays. The point is how many passes you are in need.
Actually, if I have now the FNB needle, we may have one pass and we have sufficient bone.
Okay, fine. Thank you.
Thanks.
About the standard of care, as he said, we divide these patients into resectable, borderline, or irresectable cases, depending on the infiltration of the vessels around. If all the vessels are free, this means from the start it's resectable. If we have our IVC or superior mesenteric encasement, more than 180, it's resectable. But if we have less than that, celiac, common hepatic, but celiac is not. It's common hepatic, superior mesenteric venous neck artery, 180 or less, this is a borderline. As he said, we have also a complex vascular procedures. Complex vascular procedures is going to excise or the artery or the vein and reconstruct it. We will talk about this later. So the borderline, this is a lot of the classifications, the American. So where comes the concept of borderline? We are surgeons. As a surgeons, if we have a tumor which proved to be extending little bit outside its regional anatomy, our philosophy is to extend the surgery more. This is our way. But in the pancreas situation is different because we cannot extend it because of the vessels around. So from here comes the idea of the new adjuvant therapy in these cases, because to undergrade it to resection 0, which is the only hope for these patients. 30 to 60% of borderline cases converted to resectable after the new adjuvant therapy. We'll take it later on. Just this question is pathological diagnosis necessary before resection or not? This is a question. Not all the time you will have the pathology. We are missing pathology in about 10% of cases. What is the solution then? Rebiopsy? Or how do you behave? Dr. Ahmed, is pathological diagnosis necessary before surgery, before resection or not? Suppose that US gives negative results and you have many red flags in the CT, infiltration, the mass in the pancreas. So what you are going to do? You are going to do a rebiopsy? Or
no, I will proceed without a biopsy if there is compelling evidence that we are dealing with pancreatic cancer. Pathology is part of the whole picture, but you have a picture, you have a bigger picture.
Fine.
You have a jaundiced patient, you have a CT scan, you have
mass in the pancreas.
CA 19.9. There are a lot of
red flags
that you have, and the only problem with EUS really is with every sonographic investigation you do, because it's operator dependent. A CT is a CT. You can read it, I can read it, everybody can read it. But EUS is operator dependent. So
والله دكتور أحمد حتى الCT أنا اتفرجت I watch the radiologist while they are reporting. If we have a center international, he may spend half an hour to report a CT pancreatic protocol, because he's following the vessels from the start up to the end, everyone on the software. And finally, he is writing the report. But if this situation is done here, I think he would only have 5-6 patients per day, which is who is doing 100.
No, but at the end of the day, you have the films. You can,
Yes.
if you do not like the report, you can change it. You can have a second opinion. But in EUS, you can't.
Yes.
EUS, the guy who's doing the EUS is doing the EUS, and wherever he sticks the needle, he sticks the needle, and whatever comes back, you're compelled with it, whether it's likely to be correct or not. So it's a different issue. So pathological diagnosis in obviously malignant cases is not mandatory, but you will have a borderline, not resectability, borderline diagnostic case that you should not proceed except with pathology because you can be dealing with something different.
شكرا. انا مش طبعا
Let me just comment about what
مش هسأل الدكتور طارق لانه طبعا الدكتور طارق من غير باثولوجي ملوش دعوه.
definitely I will go for pathology if the patient is not candidate for surgery before starting any treatment. Not from the ethical point of view, also because pathology might guide me the kind of treatment the patient receives. So pathology for me is crucial and very essential.
What I mean, Dr. Tariq, that if I have a mass in the pancreas, as I show in the pictures, and this mass is away from the vessels completely, and all the criteria are there, but the pathology was negative. So what we do here, and this is occurring about 10% of cases, they said that, yes, preferable that you should have a biopsy, but it's not necessary. We can bypass on some occasions. So what is the advantages of insisting to have a pathology? Of course, the advantage is the accuracy. I can speak with the patient what I'm going to do. I can preoperative plan the operation well. These are the advantages. But if it is negative, when this occurs 7 to 10%, this patient should be operated really, because about 60% of them was after the resection appeared to have a malignancy. But they put some conditions for that this should be done in special centers with a high volume and low mortality rate. And they describe it mortality rate less than 2%. We have nowadays centers that they have 0 mortality rate after Whipple procedures. The next slide is in the same thing. What is the disadvantages of insisting? Accuracy. If it is positive, it's 100%. But if it is negative biopsy, this means that it is from 50 to 65 accuracy. Why we are not rebiopsied? Because of the seeding of the needle track. We are going to avoid. This is why we are performing the CT and the staging to start. This is an algorithm how to treat these patients. On the most left there, these are the resectable cases, no doubt about resection without prior chemotherapy. I would like to ask from the study, Dr. Ahmed, Dr. Tariq, Dr. Atif, what about chemotherapy? If there is a place for chemotherapy for resectable cases prior to surgery or not? Resectable, yes.
Resectable cases should go for surgery.
Yes.
As simple as that.
Actually, this was part of my talk, but in short,
leave it to the talk.
I mean, pancreas is not like breast or even gastric cancer. In breast and gastric cancer, there is a role for neoadjuvant chemotherapy, definitely. And it has it's as a surrogate endpoint. The pathological complete response has an impact on the outcome. But in the pancreas, this is not the case.
Okay.
But definitely you have to differentiate between three scenarios, as Dr. Ahmed mentioned, those who are resectable from the very beginning, those who are borderline resectable, and those who are unresectable. And they might be a role for definitely neoadjuvant chemotherapy for the other two things.
Yes.
I mean, those who are borderline resectability or those who are unresectable.
طلعت.
مفيش جديد بقى resectable.
Exactly. So there is no place for chemotherapy prior to resectable cases. I said that because in Istanbul last year, in September or something like that, there was a session that they are starting to make some research work about chemotherapy prior to Whipper in resectable cases. They said that this is going to improve the survival rate from 45 to 65 or 60, but still in the research. It's not confirmed yet. The second one in the middle is the borderline. As we said, we will try to upgrade this patient to the resectable level if we succeed by the new adjuvant therapy. And in these situations, we might have 65% of them turn it to resectable cases, and then we are going to operate. Or they will not all progress, so we will shift the others to the unresectable cases, in which chemotherapy only play a role and some treatment of the effects of the long-standing tumor. The same thing. What about preoperative biliary drainage? Dr. Ahmed, Dr.
If possible, if we can operate without preoperative biliary drainage, this is the best thing. If the bilirubin is not very high and you work your patient quickly, get to surgery without biliary drainage, this is the best. Putting there is no personal cutoff, but it's something between you and the anesthesiologist also who's going to take care of the patient. But I will operate up to 15 without the biliary stenting.
You mean it?
Yeah, if the patient is under coverage of antibiotics and having normal renal functions. Otherwise, you will have to put a stent, because a stent complicates things. It increases the rate of infection, and they have their own problems. The worst thing at all is when you have a lesion which is obstructing the ampulla. So you are putting a PTD, and this really is a very bad situation. I just operated last month a case like that, and I had the inserted PTD because I'm inflating the patient during laparoscopic, so you will have your PTD protruding through the skin to the liver, and there is biliary leak all around it. It's really a big mess. So if you can operate the patient without drainage, it's much better.
As a matter of fact, طبعا دكتور علاء طبعا addressed that امبارح yesterday I mean but actually still in debate. But if you have a higher level of bilirubin, I would advise the internal drainage, I mean ARCB and stenting, provided the patient is not having impaired kidney function or signs of sepsis, or don't forget the coagulopathy as well from that prolonged high bilirubin.
Thank you. Yes, it's really the situation as Professor Ahmed and Professor Atef said. If we have cholangitis, yes. If we have delay in surgery, yes. The patient is going to have a new adjuvant therapy. He cannot withstand all this time without biliary decompression. If the patient is poor nutrition, but elective surgery with jaundice, we have cut off the most accepted cutoff is 15, but many centers reach up to 20. And the others said that as long as the patient general condition is good, the hepatic functions are good, coagulopathy is good, you have to do it whatever the number is. Because really I prefer to operate this patient without a stent. The problem of the stent, especially the new fully covered stents and the pericholangitis performing, is very difficult, even in the reception or in the anastomosis later on. So ERCP is the only tool, is the preferable tool to perform a stent. Which type of stent? This is another question. Plastic stent or fully covered metal stent?
Plastic stent is being a
Plastic
temporary
stent,
one.
of course.
Temporary one, because
plastic stents, if you're going to operate directly, if the patient is going for neoadjuvant, this is a different thing. Because, sometimes you need to put a fully covered stent to bridge, to bridge the time or else the patient will change the stent 10 times by the time he finishes chemotherapy.
Exactly. If it is for a short time, few weeks, then plastic. If the patient will have neoadjuvant therapy for a long time, it's preferable to put the fully covered metal stent, because they make a cost-effective analysis of that difference, and they found that in the second type of patients, which will stay a long time, putting a metal fully covered is less costly than repeating the plastic stent, as Dr. Ahmed said. I show you how in USA they are fighting to increase the survival rate. They are starting from 7, and in 2008, the overall survival rate of cancer pancreas was less than 5. But every year, they are putting that, announce it in all the media. Early detection saves life. If it is early, you will get 80% survival. If it is late, it's less than 5%. And they start 9, 11, 10, 11, till they reach that 11 in 222, yes. 2022, exactly. But at the same time, look for the costs they are spending to achieve that survival rate. It's too much, really, but they gain a good benefit. Now we come to our interesting point for the Whipple procedure. I'll summarize it. Just it's 4 transections, 3 anastomoses. In 1970, the mortality rate was 31%, and the morbidity was 50%. In 2011, mortality less than 5%, and the morbidity was 25%. And nowadays we have mortality less than 3 and even 0% in some centers, but the morbidity is not that significantly decreased, and this is another story I will later speak about. We know that we have the classic standard Whipple procedure, which is well known for all the others. And what the surgeons are doing, in addition to, they are trying to localize the tumor size to put it in the resectable range. They make some refinements in surgery to achieve the goal. These refinements include pylorus preserving, difference in the techniques, posterior than anterior, artery first or not. I will let Dr. Ahmed Shukri highlighted this project.
Okay, we are in 2023 now. This talk was a few months ago, so it was still 2022.
There has been, as Professor Yahya showed, the data from the 70s to the early decade of this century to this decade we are in. There has been a lot of evolution in the management of pancreatic head cancer, evolution in the technique, and evolution in the technology that we're using, and evolution also, which is very importantly, in the concept of radicality. And this is my main thing. I will focus on the evolution of the concept of radicality. There is absolutely no point for you to perform a pancreatic head cancer or surgery to do a Whipple without achieving an R0 resection. If you do not achieve an R0 resection, you did absolutely nothing for the patient. You have performed a heroic procedure for just surgical exercise. And for years, our limiting factor in the decision of to resect or not to resect was the vein. And if you have a CT with involvement of the vein, so you abort the idea of operating. If the vein is clear, you go ahead and explore the patient. This has long gone. Now, nobody is talking about the vein anymore because the vein is expandable. You can resect it, you can patch it, you can graft it, you can do whatever you want with the vein. So nowadays, the focus on the resectability lies on the artery. If you have an artery which is not involved by tumor, most probably you can perform your surgery. And another issue that we are going to touch on today is the concept of the mesopancreas. What should we exactly resect while during a pancreatic disectomy? So these 2 points are the main focus of the Whipple in 2023. This case, with the left sided picture, there is a grossly involvement of the vein, and by the end of the surgery, you see that the vein has been resected and grafted, and the procedure has been finished completely. In 2006 came up a terminology that was relatively novice, which is the mesopancreas. The mesopancreas. What is this story of the mesopancreas? You will find in different publications, depending on the geographical origin of the publication, whether it is coming from Japan, from Europe, from the States, you will see a different nomenclature for what is the same thing. The retropancreatic duodenum, the retroportal lamina, the PA ligament, they are all the same nomenclature to the same thing. But anatomically, what are we talking about? The mesopancreas is the plate-like structure which lies between the pancreatic head, the celiac trunk, and the superior mesenteric artery, to put it as simple as possible. And what do we need to know about this mesopancreas? In a very detailed anatomical study, they cut the block of the pancreatic duodenectomy specimen in a cadaver, and they dissected away the structures that you cannot remove in the patient to expose, like in the third picture from the left, to expose
what tissue lies between the pancreatic head and the uncinate process and the superior mesenteric artery and the celiac artery. And this area, this specific piece of tissue where there is a very abundant perineural tissue, is where you find most of the recurrences after Whipple. And this is why the patient dies, because there is a spread retroperitoneally along these neural bundles around the superior mesenteric artery. And this is, if not resected, the patient would develop recurrences. This is a highlighted picture where exactly this lies. It is not in the head anymore. You are not operating on the head. This is tissue that is between the head and the superior mesenteric artery and the celiac trunk. So at the end of your surgery, you need to have a picture like the right one, that the superior mesenteric artery has been completely cleared of all these tissue, the tumor harboring tissue. So this is a picture where the focus of interest is no longer the pancreaticoduodenectomy block, but the area, retroperitoneal area, with the perineural tissues around the superior mesenteric and celiac trunks. It's the same thing. And from this concept, the Heidelberg group, Boschler and Thilo Hacker, they developed what is known as the triangle operation. And in essence, what you need to do is that between the superior mesenteric artery and the celiac trunk, there should be no more tissue by the end of your surgery. This is exactly what you want to do. And even in locally advanced cases where you are going to resect vein, when you are going to resect vein, it is not a problem as long as the vein becomes a piece of your pancreaticoduodectomy specimen, and at the end of the surgery you will have a clear superior mesenteric celiac axis. So, in concept, the artery first pancreaticoduodectomy, you aim at complete mesopancreas excision, and which is very important in all the cases that are borderline or the cases that have received prior neoadjuvant chemotherapy, you assess resectability after neoadjuvant much better when you go to the artery first, and then you clear the artery so that you know you can resect the vein if necessary, but at least your artery is safe and you can proceed with the resection. There are 6 approaches in this very nice paper in the British Journal of Surgery by Sanjay Itar. 6 approaches to the artery first technique. There are very famous approaches and there are less common approaches. You can approach the artery after full mobilization of the cochlearization of the duodenum and pancreatic head. You can approach it in the mesentery, below the colon, in the mesentery, above the colon, underneath the pancreas. There is Nagakawa in Japan described the uncinate process approach. We are going to see in the videos some of these approaches. This was a breakdown in what is present in the literature regarding the artery first approach in minimally invasive surgery only, not in open surgery. But I will leave the videos later on after we discuss the classical open pancreatic duodenectomy that will be presented.
خلي الكلاسيكال اوبن هنا. كمل انت على اللاباراسكوبي.
كمل انا؟
على اللاباراسكوبي.
start classical please يا
unstarted cassette.
ستاندرد ويب عنده الفيديو محمد احنا we are going to depict a small video for a couple of minutes for the standard Weber procedure, which is basically most of the surgeons that perform Weber procedure do this, except طبعا Dr. Ahmed Shukri and some other surgeons. Still the standard procedure all over or worldwide is still the open procedure. We're going to depict this procedure, and we have to realize that resection of the mesopancreas, what we call the mesenteric margin, in the form of, in the open procedure, we have to skeletonize the superior mesenteric artery. You can see here, this is a mass with identifying the after we resect, you can see the stent here in the pancreatic duct. Here is the superior mesenteric vein. And the artery. Okay. This is superior mesenteric artery. Here, if you did not take out the inferior pancreaticoduodenal artery and skeletonize the superior mesenteric artery, there is no pointer, unfortunately. So, next video. This is inferior pancreaticoduodenal artery ligature. This is very important in order to skeletonize all the way up the artery until the celiac trunk. You can see the superior mesenteric vein is, little bit retracted. Of course, this video, because the last one, please. This after you take out the specimen with you can see the mass and the mesopancreas and the gallbladder with, of course, the big mass. This is the mesopancreas that we are talking about. You will see the artery, bulldog on the common hepatic duct. You can see skeletonized, the artery all the way skeletonized. You can see this is right there, yes, superior mesenteric artery with the Baker on it, superior mesenteric vein, the portal vein, and the artery down there. And that's it. You can see the anatomy is clearly identified, I believe. And this is next step, of course, the reconstruction. Thank you so much.
Thank you, Professor Atif. الفيديو هذا فولدر طبعا unfortunately Dr. Muhammad Abab was supposed to speak about this item, but he was sick, so we replaced him urgently. We have no videos. I will speak till Ahmed is ready. Ready, Ahmed?
I'm ready.
Okay, fine.
This is one of the my preferred approaches for artery first in minimally invasive surgery. We go the mesenteric approach, the inferior mesenteric approach, which is infracolic. We tackle the area of the middle colic vessels. We expose the superior mesenteric artery, and we encircle it and make sure that there is absolutely no tumor in the vicinity of the artery along its whole length in this area. So after ensuring that the artery is free, we can embark on the pancreatic adenectomy. We can start resecting without worrying about the vein too much. If the vein is involved, it will be resected. So this is one of the approaches. We will see, this is another video with the same approach, the infracolic mesenteric approach in the area of the middle colic vessels. The artery here is readily accessible. It's not a difficult exposure. It's relatively easy, and it gives you the preparation of the dissection of the DJ and the resection of the jejunum, as we are going to see later on. So now we have a very good plane between the artery and the vein. And you see here, this is the cauterization of the duodenum and what is termed as the posterior approach to the artery first technique. This is the IVC, the renal vein, and we have completely cauterized the duodenum, and we start dissecting above the renal vein around the root of the mesenteric artery, taking off from the aorta. So you can expose the artery here and you can start dissecting even a little bit the artery from the uncinate process. So you see here, just above the renal vein, the superior mesenteric artery origin, right there. And a third approach is the infra-pancreatic mesenteric approach, below the lower border of the pancreas. We ligate the branches of the gastrocolic trunk of Henle, and then we expose the artery, dissect it, and make sure that the right side of the artery is away from the lesion and the tumor, and you can encircle it. Okay. Now the story of the mesopancreas and what relation it has to the artery first technique. As I said, the preparation of the artery in the mesenteric plane here makes it very easy. This is the artery prepared, and so on. We cut the jejunum and come from the left side. The section is very clear and just around the artery. You remove all the tissues and the lymphatics from the left side. In the classical Whipple, you try to do this from the right side. So you are trying to bring the whole specimen to the right. But now when we finish, and then you push the specimen to the left, and you see here the superior mesenteric artery is very clear. And now about this mesopancreas. To get to resect the mesopancreas, you have to dislocate the inferior, the portal vein and the superior mesenteric vein away from the retroperitoneal structure. So we are now dislocating the whole portal superior mesenteric complex out of its bed to get to these tissues lying between the head, the superior mesenteric artery, and the celiac trunk. And gradually, you take down the whole tissues that are in between. So this is the essence, this is the origin of the superior mesenteric artery from the aorta, and you are taking the whole tissue that is intervening between the superior mesenteric artery and the celiac trunk. Above, you see the hepatic artery with the gastroduodenal artery with a clip on it, and this is the remaining tissue that is still holding. So we are taking it out now. So now you have dislocated the whole mesopancreas away, and we will see the bed of the resection. You see the artery here, the vein there, and you see the origin of the superior mesenteric artery and the celiac trunk coming out of the aorta, and there is absolutely no tissue in this area at all. A complete resection of the mesopancreas. This is another case with the same concept, so that you understand exactly that we have standardized the approach to this area. This is the superior mesenteric artery and the middle colic, and then we start, after exposure, we start cutting the jejunum and sending it to the right side, and then again the mesopancreas. You have to dislocate the portal superior mesenteric vein complex away from the retroperitoneal tissue to expose the mesopancreas completely before resection. So now we are releasing the portal vein with sometimes you will find branches coming in, and then after full mobilization of the portal and superior mesenteric vein, you can start resecting the mesopancreas. And we will use here, you see, you went to the opposite side, and we are going to use the tape on the superior mesenteric artery to retract the vein, so that we can approach the mesopancreas directly. This is the superior mesenteric artery. We're talking all the tissues around it. Up to the celiac trunk. And you should here really need to be very careful, because sometimes there is an aberrant right hepatic coming from the superior mesenteric, as you are going to see in this case. So you are really dissecting along the superior mesenteric artery very carefully. All this is the neural complex that we are talking about that you need to resect. And now this comes the aberrant right hepatic, and it is going all the way up. And now, after completely resecting the mesopancreas, we are continuing the section up to the CBD, and we are preparing the CBD for transection. This patient had stent in. So this is what we do in the artery first, and the mesopancreas resection laparoscopically, and we can discuss.
This is طبعا standard, very nice, but I'd like to add something very important in the procedure of Weber procedure, either laparoscopic or open procedure. You cannot take out the mesopancreas completely without retracting the superior mesenteric vein and the portal vein, as you can see in this video. You cannot. I believe, and there is no difference in the literature, Dr. Ahmed, as regards the artery first versus the standard procedure in terms of, but I think that you feel gives you that you are very comfortable and you feel safe in an issue of laparoscopic rather than our open bed technique. All right, but in open surgery versus the same steps and the same procedure. You cannot take mesopancreas without retracting and clearing the superior mesenteric artery without retracting the superior mesenteric vein, as you can see, either in the open procedure or in the laparoscopic procedure. This is something.
Thank you. Thank you, Professor Ahmed, for this nice presentation. حقيقة, truth, there is no difference between laparoscopic and open surgery. The artery first techniques makes you comfortable. Before doing any irreversible resection, you are safe about the artery, then you can think later on of what's going on. But of course, if we do something with laparoscopy, we will gain the benefits of the minimal invasive surgery and the magnification power, and especially in this area, which is posterior. This area is not accustomed for the open surgery. The open surgery is working anterior. It's difficult to reach that place without laparoscopy. The only thing is not everyone have the power to work 7 hours. So I think the limitations of laparoscopy and that field, it needs for a team, double team. Team is going to resect and team is going to reconstruct. It's very hard to stay 7 hours. How many hours, Dr. Ahmed, took the procedure?
It depends. Sometimes.
Depends, yes, but
sometimes 5, sometimes 8.
Sometimes
on
8.
the case.
So not everyone had the mentality to keep him awake for 8 hours on the laparoscopy. Let us jump to another point in the procedure. Which we prefer, pancreaticojejunostomy or pancreaticogastrostomy, but we have no time. We have to make the answers a little bit more quick. Which of course, the standard Whipple was pancreaticogastrostomy. I prefer the pancreaticojejunostomy, no doubt about that. Yeah.
My standard of care is pancreaticojejunostomy.
Okay.
I don't do pancreaticogastrostomy.
A technique of anastomosis, which sutures you are using. This is important, really.
Most probably, I'm using a combination of proline, 5-0, 4-0, and PDS.
PDS.
5-0, 4-0, depending on the size of the duct, the pancreas. If it is soft pancreas,
did you prefer
hardened fibrotic pancreas?
Ductal mucosa technique?
Ductal mucosa, yeah. Ductal mucosa.
Dr. Atif.
If there is a duct.
No, it's a matter of preference of surgeons. As regards my personal experience, I'd like the pancreaticojejunostomy. Ductal mucosa end to side of the jejunum with double layers, as we say, and interrupted sutures, and I use always proline, 5-0, all right, with internal stent. Sometimes because duct, sometimes internal stent rather than any external stent. We used to do external stents. This is in the early experience, but now we do internal stent.
Okay.
But if you have a soft pancreas, it's really a great problem.
This is what the next question. Does pancreatic consistency affect if it is firm or soft? You are going to change your technique. I change it. Dr.
Let Ahmed Bai.
Yes, of course. If there are a lot of problems that you can encounter in the due process of your pancreatic anastomosis. Sometimes you have a very nice wide duct and a very hard pancreas. You can put bites in like you want, and sometimes every bite you take in the pancreas just cut through, and you have a very small duct. Or sometimes you fail to find the duct to start with. So you really, if you have a good duct, you have a good pancreas, you can go for pancreatic duodenostomy, ductomucosa, no problem at all.
Yes.
But the problem starts when you have a very soft pancreas, or you cannot identify a good duct, or the duct is too small to be anastomosed. So in this examples, I go for invagination of the pancreatic stump in the jejunum without ductomucosa.
Usually, why the consistency changes? Because in nearly 10 to 15% of cancer pancreas, they have an associated pancreatitis, which is going to change. What do I leak? What to do if leak happened? Very shortly, please.
If you have, usually we conserve, it depends of course if it's minor leak, usually conserve. And of course follow up with the amylase. All right, the amylase in the drain, level of the amylase in the drain. If it's dropping and the amount is dropping, you can conserve, usually conservative. And I would rather add, most of the pancreatic leak is a technical error nowadays.
مش لازم technical.
Unless your pancreas is soft
طبعا.
and the duct is small, at that time you can do the dunking or whatever, just invaginate the jejunum. This is I'm talking about the standard open procedure, not the laparoscopic, right?
Hamid, the same, huh?
It depends on the amount of leakage, the systemic effect of the leak on the patient. The patient is septic, the patient is not septic. I don't think that there is a pancreatic anastomosis that does not leak.
Yes.
All pancreatic anastomosis leak. But
there is a percentage.
I'm even objecting to the term of a pancreatic anastomosis. An anastomosis is between two hollow organs. You cannot anastomose a parenchymatous organ to bowel. This is physically impossible. What we are aiming really is to do an internal fistula. Is to fistulize the pancreas into a hollow organ, whether it's the stomach or the jejunum. But and this is why leak is very common, because this is not a hollow organ to hollow organ, and they will just anastomose together. This is a parenchymatous organ that you are trying to fix into a bowel. So a lot of them they go conservatively, no problem. If you have to intervene for you can intervene by interventional radiology if you have localized collections and you cannot drain them properly. And sometimes you have to intervene surgically if there is a gross problem or there is bleeding.
Yes, well, the problem with the pancreatic leak, which we have to be sure that we have a good drainage, really, because this area is quite close to the gastroduodenal artery, which is ligated. So these patients might have terrible bleeding from the site of the gastroduodenal ligation. Hepatocolonicojejunostomy, okay, technique of anastomosis. Did the caliber of CDBD affect stent or without stenting? We will answer this question very rapidly.
Wide duct, no stent. Narrow duct, I stent. The technique, if you have a wide duct, single running suture, PDS, usually 3O, 4O, depending on the size of the duct. If you have a very small duct, I stent, I run the posterior wall and interrupt the anterior wall.
really this is not a big deal, because after the experience we have got in the liver transplant, and thanks to Professor Abu Wahab and all his team for helping us on that, the biliary anastomosis is no more a problem. But the stenting is not really preferable. In most cases, especially when they even 7 to 8 millimeter diameter, you have no need for stenting. Now, we are coming to the point where Dr. Tariq Hashim should provide us what he's going to do in the borderline cases to upgrade it to the resectable, and what he's going to do in the unresectable cases together with EUS nowadays, which is successful in controlling the pain by transilic. لا دكتور طارق تعال transilic infiltration of the celiac plexus, and the jaundice also, and also the gastric outlet obstruction by US nowadays. They can do gastrogenostomy, and they can do hepatogenostomy.
Before I start, I must thank Professor Yahya Zakaria and the organizer for giving me this great opportunity to be here with you and share in these very great discussions. Here is my disclosures. During the next 15 minutes, I will focus on three main things: the role of neoadjuvant adjuvant therapy in patients with pancreatic cancer, in metastatic setting, the role of systemic therapy, in the absence of actionable molecular alteration, and in metastatic setting, the role of systemic treatment in patients with actionable molecular alteration. As Professor Zakaria highlighted, this is the magnitude of the problem. In the United States, about 60,000 cases annually, and the death rate is about 48 cases in the year 2021 in the United States. Stage by stage pancreatic cancer is associated with the lowest survival rates of any major cancer type. And within the decade, pancreatic cancer is expected to rise to the second leading cause of cancer-related mortality in the United States. What about the situation here in Egypt? According to Globocan 2015, there was about 3,000 cases. In that year, the death rate was about 2,800 cases. We're talking about resectability, resectable disease, the role of neoadjuvant and adjuvant therapy strategy. So as I've already mentioned, pancreatic cancer, there are three scenarios or three categories: those who are resectable from the very beginning, those who are borderline resectable, or those who are unresectable or locally advanced. There are many trials addressing the role of neoadjuvant treatment in patients with pancreatic cancer. The problem here is the inclusion criteria. It's heterogeneous. For instance, in this trial, they included patients with resectable and patients with borderline resectability. In the first arm, or the experimental arm, patients receive systemic chemotherapy. You all know the gemcitabine or the Gemzar, followed by concomitant chemo radiotherapy, and then chemotherapy Gemzar, and then they proceed for surgery. And in the other arm, they went to upfront surgery. The primary endpoint of this trial was overall survival, and the secondary endpoint were R0 resection. And we are oncologists. We always look at the figures and the numbers, which are much more important for us. So here in the median overall survival, there is no big difference, but there was a trend to improve survival in patients who did receive preoperative radiochemotherapy. 16 months median overall survival for the experimental arm versus 14.3 months for the upfront surgery. But if we look here, we find that the R0 resection is much higher in the experimental arm, the preoperative radiochemotherapy arm, 71 versus 40%. Also, the median loco-regional failure-free interval was in favor of the experimental arm, and the hazard ratio was 0.56 in favor of adding or giving neoadjuvant concomitant chemoradiotherapy. Again, in this study, we were talking about heterogeneous group of patients. Part of these patients has a resectable disease at the very beginning, and the other part had borderline resectability. This is another trial, and it was in the Asian patients in Japan and North Korea. And in this trial, patients again were randomized to receive either gemcitabine plus S1, which is a fluoropyrimidine common in Asia. It's like 5-fluorouracil here. So this patient received gemcitabine plus S1 for 2 cycles, followed by surgery, and then another 6 cycles of chemotherapy or upfront surgery. And if we look at the survival curve, it was in favor of neoadjuvant chemotherapy with a hazard ratio of 0.72. This is another interesting trial addressing the role of perioperative chemotherapy in patients with pancreatic cancer. Patients with resectable, here is the patients who were resectable, pancreatic adenocarcinoma, no previous cancer therapy. This group of patients were randomized to receive 2 different types of chemotherapy, what we call modified FOLFIRINOX, or gemcitabine plus nab-paclitaxel, then followed by restaging, surgery, and another 6 cycles of either modified FOLFIRINOX or gemcitabine plus nab-paclitaxel. The primary endpoint of this trial was to achieve a more than 55% increase in a 2-year increase in overall survival. And if you look at the data of this trial, our resection were more or less the same in the 2 lines of chemotherapy, no difference in terms of R0 section, while in this study the 2 arms did fail to meet the primary endpoint, which was the 58% survival at 2 years. Lastly, the CONCUS 227 trial, which was published in the last ASCO meeting, which is the biggest oncological meeting worldwide. And in this phase 3 trial, which is including a good number of patients, more than 400 patients, this group of patients were randomized to receive induction chemotherapy, gemcitabine or FOLFIRINOX, and then randomized to receive either concomitant chemoradiotherapy or to continue on therapy. Again, induction followed by either concomitant chemoradiotherapy or to continue on systemic chemotherapy, and then patients were reassessed for resectability. The primary endpoint of this trial was arterial resection, and the secondary endpoint was overall survival, disease-free survival of resections. Here is the baseline characteristics, and if we look at the patient's characteristics, we'll find that the majority of the patients were locally advanced, 35% T3 and about 52% T4. So the majority of the patients, more than 75% of the patients were locally advanced. If we look at the data of this trial, we'll find that the R0 resection was in favor of the chemotherapy plus radiotherapy, the concomitant chemoradiotherapy arm, 69% versus 50%. Also, the resection margin, the negative resection margin was higher in the concomitant chemoradiotherapy when compared to chemotherapy only. But if we look at the data of the progression-free survival and the median overall survival, there was no difference between patients who did receive concomitant chemoradiotherapy and those who did receive neoadjuvant chemotherapy at the beginning. But if we look at the subgroup analysis, we'll find that the patient who did achieve the longest overall survival were those who did achieve R0 resection and those who had negative surgical margin, 36% median overall survival, which is, in pancreatic cancer, it's a very long period, 36% median overall survival in patients who did achieve a negative surgical margin. In terms of toxicity, definitely toxicity was much higher in patients who did receive concomitant chemoradiotherapy in comparison to those who received only neoadjuvant chemotherapy. So the conclusion of this trial, the addition of radiotherapy after induction of chemotherapy significantly improved R0 resection rate in surgery group, but not in all patients with unresectable locally advanced pancreatic cancer. Progression-free survival and overall survival were similar for patients who did receive chemotherapy and those who did receive concomitant chemoradiotherapy. And the investigator concluded that induction chemotherapy followed by additional chemoradiotherapy and surgery in unresectable locally advanced pancreatic cancer is feasible with a 5-year overall survival rate of 9.6 and up to 26.9% in a selected subgroup of patients, those who did achieve R0 resection and had a negative surgical margin. There are many other ongoing trials addressing the role of neoadjuvant chemotherapy in patients with pancreatic cancer. Again, up to this moment, we don't have enough data about the subgroup of patients who get the maximum benefit from neoadjuvant chemotherapy. This is because of, in the most of this trial, the heterogeneity of the inclusion criteria and the difference in terms of the primary endpoint in these trials. What about adjuvant chemotherapy? Again, it's a very easy answer. Adjuvant chemotherapy did improve the outcome in all patients following resectability. This was based on many randomized trials. The first trial addressing the role of adding capecitabine to gemcitabine, which was the standard of care at that time. And in this trial, there was improvement in terms of median overall survival for patients who did receive the combination of gemcitabine plus capecitabine in terms of survival following surgery. The PRODIGE trial, which is one of the biggest trial, comparing the modified FOLFIRINOX versus the standard of care at that time was gemcitabine, and the primary endpoint of this trial was disease-free survival, and the secondary endpoint were toxicity and overall survival. And in this trial, again, there was an improvement in terms of disease-free survival and overall survival for patients who did receive modified FOLFIRINOX. And the other trial is addressing the role of different regimen, the nab-paclitaxel plus gemcitabine versus gemcitabine. And the primary endpoint of this trial was disease-free survival. The secondary endpoint were overall survival. And in this trial, there was no difference in the disease-free survival, but there was a trend for improvement in the median overall survival for the nab-paclitaxel and gemcitabine when compared to gemcitabine alone with a hazard ratio of 0.82. So according to this data, if you ask me about what is the standard of care for patients following complete surgery, the standard of care is to receive modified FOLFIRINOX as an adjuvant treatment because its impact on the outcome, mainly it did improve the median overall survival. What about metastatic disease? The role of systemic therapy in the absence of action with molecular alteration. Again, the two main regimen, the FOLFIRINOX or the gemcitabine plus the nab-paclitaxel are the standard of care for treating patients with metastatic unresectable pancreatic cancer based on two main phase 3 randomized trial that did show improvement in terms of the outcome in patients with metastatic pancreatic cancer when they did receive either FOLFIRINOX or gemcitabine plus nab-paclitaxel. Here it's not head-to-head trial, but if we look at the data of the two trials, we'll find that the response rate was much higher for the FOLFIRINOX when compared to the nab-paclitaxel plus gemcitabine, 32% versus 23%. Disease control rate 70% in the FOLFIRINOX arm, and it was 48% in the nab-paclitaxel gemcitabine arm. And the median progression-free survival 6.4 versus 5.5. Median overall survival 11.1 versus 8.5. But we have to put, these are the survival curves for the two trials, the FOLFIRINOX plus versus gemcitabine and the nab-paclitaxel versus the gemcitabine. Definitely the median overall survival was in favor of the first trial, the FOLFIRINOX when compared to gemcitabine. But here, definitely, if we look at the adverse events is much higher in the FOLFIRINOX when compared to gemcitabine plus nab-paclitaxel. And here is, we always look at the performance status of the patient and the quality of life before selecting which type of systemic chemotherapy the patient should receive. Here is a sort of consensus or guidelines for treating patients with metastatic pancreatic cancer, mainly based on the age. Here it's 80 years, whether it's above or below 80 years, and the performance status, less than 80 years, performance status 0 to 1. This group of patients should receive either FOLFIRINOX or gemcitabine plus nab-paclitaxel. What about maintenance therapy? It's always a question when to stop treatment. If the patient is responding, to what extent should I continue treating the patients? There are many data about giving a sort of, or maintaining the response I achieved by giving the systemic chemotherapy. If the first line is FOLFIRINOX, we can continue giving maintenance chemotherapy, less aggressive regimen to continue what we are already achieved by giving the first line chemotherapy. So if the patient receives FOLFIRINOX, we can continue giving either FOLFIRI or more delicate regimen, which is the capecitabine plus or fluorouracil. And if the patient did receive gemcitabine and nab-paclitaxel as upfront, we can maintain the achievement by giving either modified gemcitabine plus nab-paclitaxel or gemcitabine as a monotherapy to maintain the response we achieved. What about second line in patients with metastatic pancreatic cancer? The standard of care or the best second line of to give the combination of what we call liposomal irinotecan and fluorouracil based on the data of the Napoli 1 trial. In this trial, patients were randomized into 3 arms. The first arm received irinotecan or liposomal irinotecan. The second arm received 5-fluoro plus leucovorin, and the third arm received the combination of the two drugs together. And the primary endpoint of this trial was overall survival, and there was an improvement in favor of the combination of liposomal irinotecan with 5-fluorouracil. So this combination is considered as a standard of care as a second line for patients who fail on first line, either modified FOLFIRINOX or gemcitabine plus nab-paclitaxel. Again, this is the how can we treat patients with metastatic pancreatic cancer, the sequence of therapy. First line, if the first line is gemcitabine plus or minus nab-paclitaxel, the second line would be modified, would be liposomal irinotecan plus 5-fluorouracil, and if there is a chance for the third line, it would be FOLFOX. And if the first line is for FOLFIRINOX, the second line mostly would be gemcitabine plus or minus nab-paclitaxel. But we should keep an eye on the adverse events and the quality of life for the patient before starting either the second line or the third line. Metastatic disease with targetable or actionable molecular alteration. What is precision medicine? I think we all know about it. We heard about it. It's molecular testing for the therapeutic purpose. In any individual patient, there may be a distinct targetable molecular abnormalities. Definition of actionability, we have a mutation that we have a treatment for this kind of mutation. This is what we call is actionable mutation. In pancreatic cancer, if we look at the actionable mutation, the NGS efforts have consistently revealed that more than 25% of pancreatic cancer have potentially high actionable molecular biomarkers. Mainly 5% is the BRCA, and the other mutation is in the range of 4% and 1%. So we look at from the economical point of view whether we have to focus on the BRCA only because of its relatively, the prevalence is relatively high, 5% compared to the other, or we have to go for all the panel before starting treating patients with pancreatic cancer. This is a very interesting point regarding the gold standard overall survival benefit of the actionable mutation. In this trial, they included more than 1,028 patients with pancreatic cancer who underwent molecular profiling or by NGS. Of these patients, 677 patients with outcome information. Yani 677 patients has an outcome information. Of this patient, 189 has actionable mutation. 189 has actionable mutation. Of this group of patients, 46 received molecularly matched therapy. Actionable mutations received actionable therapy in 46 patients. If we look at the data, definitely improvement, dramatic improvement in terms of median overall survival for matched group when compared to unmatched group, or those with who did not receive, or those with no actionable mutation. The best survival was for the group of patients who had actionable mutation and did receive treatment for this actionable mutation, when compared to the other groups, those without actionable mutation or those with actionable mutation and did not receive therapy for this actionable mutation. Also, this is a slide showing the difference or how can we predict the outcome for before starting treatment, the DNA damage repair in patients with DNA damage repair, and the relation of this damage repair to the response to mainly platinum drugs. And in this slide, we can show that there is a difference in terms of the outcome between those who has deficient DDR and those who has proficient DDR when received platinum treatment. If we look at the prevalence or the percentage of actionable mutation in patients with pancreatic cancer, 5 to 7% of patients with pancreatic cancer have germline BRCA1 and 2 mutation, and about 40% of the patients who are germline BRCA1 and 2 mutation carriers do not have family history of breast or ovarian cancer. Oh, so germline testing is recommended for any patients with confirmed pancreatic cancer using comprehensive gene panel for hereditary cancer syndrome, and we have to put it in the guidelines. And for regarding the tumor somatic gene profiling is recommended for patients with locally advanced metastatic pancreatic cancer who are candidate for anti-cancer therapy to identify uncommon but actionable mutation. This is one of the trials addressing the role of the benefit of actionable mutation in treating patients with pancreatic cancer. Following chemotherapy, patient who did achieve response to systemic chemotherapy as a first line and have BRCA mutation, this group of patients were randomized to receive either olaparib, which is a PARP inhibitor given in patients with BRCA mutation, or placebo. And the primary endpoint of this trial was progression-free survival, and as you see here, there was a difference in favor of olaparib when compared to placebo in patients who did achieve response with chemotherapy and maintained response by giving olaparib, which is a PARP inhibitor. And if you look at the survival at 3 years, there was 33.9% versus 17% for the control arm or the placebo arm. And the first subsequent cancer therapy, as well as the PFS2, was in favor of the experimental arm, the olaparib, when compared to placebo. In terms of safety, this drug was very safe, and I have a patient with pancreatic cancer, metastatic pancreatic cancer, who did respond to systemic chemotherapy, and he remained on the olaparib now for more than 2 years. 2 years maintained response by giving this kind of drugs. What about other additional targeted agents? The MSI. We have immune therapy that can be given in patients with MSI high, and NTRK fusion. We have another drug that can be given for this mutation. Also, the BRAF, anti-BRAF, are also being investigated in patients with pancreatic cancer. And here I wish to thank you for listening, and I'm ready for any questions.
دكتور
خلاص في فينيش
يعني فينيش احنا بس عشان قبل خلاص انت خلصت كده عشان بس نقول للناس حاجه
ده بعديها. Finally, surgery is the only hope for cure. Don't forget that. I would like to thank the professor sharing me the panel discussion, Professor Dr. Ahmed Shukri, Professor Dr. Abdel, Professor Dr. Tariq Hashim, Professor Dr. Mahmoud Al-Ansari. And also I would like to thank Professor... يا أخي أصبر بس يا عم أصبر. And also I would like to thank Professor Dr. Muhammad Farid and all the members of the Egyptian Surgical Society for inviting us. And I would like to thank the ground for waiting and good listening and the time we spent for them. Thank you.
في نهايه المؤتمر احنا مش هنتكلم كتير، متشكرين لكم جميعا. المؤتمر كان ريالي سكسسفول، واحنا متشكرين على الحضور ومتشكرين على كل حاجه. احنا دايما اخر المجموعه الاخرانيه اللي في اخر محاضره اتعذبت، فبناخد صوره جماعيه هنا يعني عشان التعذيب بس يعني عشان انتوا اتعذبتوا النهارده يعني. يعني هنا بقى نقف ناس فوق وناس تحت وحاجات كده يعني تيجي يعني. عندنا مصورات كويس بيقدر يجيب حد يجي هنا، حد يجي فوق وحد تحت كده يعني. كل سنه وانتم طيبين ورمضان كريم بقى باذن الله يعني.
Recording stopped.